The child with integumentary dysfunction, we're gonna start with bacterial infections. The first one we're gonna go over is impetigo. Important to know about impetigo, the clinical manifestation, exudate drive to form heavy, honey-colored pus. When you see honey-colored pus, think of impetigo right away. All right. Treatment. This is a bacterial infection, so the patient's going to get topical bactericidal ointment. They can get mupirocin or triple antibiotic ointment, and it tends to heal without scarring. Cellulitis, caused by strep, staph, inflammation of the skin and subcutaneous tissues with intense redness, swelling, and firm infiltration. Let's talk about fungal infections, tinea. All types of tinea, guys. Tinea capitis, tinea crura, tinea pedis. These are, when you see tinea, think of fungus. These are fungal infections. I want you to think of a ringworm. The dermatophytosis ringworm are infections, caused by a group of closely related filamentous fungi that invade primarily the stratum corneum, hair, and nails. We'll go over the different types shortly. Nursing care of fungal infections. When teaching families how to care for ringworm, the nurse should emphasize good health and hygiene. Children should not, because it's very contagious, guys, children should not exchange grooming items, headgear, scarves, or other articles of apparel that have been in proximity to the affected area. That child can touch that ringworm and then touch another part of their body and cause auto-inoculation, okay? Affected children are provided with their own towels and directed to wear a protective cap at night to avoid transmitting the fungus to bedding, especially if they sleep with another person. All household pets should be examined for the disorder. Other sources of infection are seats in locker rooms, tanning beds, seats in public transportation vehicles, helmets, and gymnasium mats. Both 2% ketoconazole and 1% selenium sulfide shampoos can reduce colony counts of dermophytes. The shampoo should be applied to the scalp for 5 to 10 minutes, at least 3 times a week, and the child can return to school after the therapy has been initiated. But they still can't share anything like hats or scarves or combs or brushes. Alternatively, if the child treated with the drug griseofulvin, the therapy frequently continues for weeks to months. It takes a very, very, very long time to get rid of that fungal infection. And there's something very important you guys have to know about this medication. When you see griseofulvin, I want you to think of grease. Guess what? It's the grease, the fat that activates the medication. So you have to teach the parents when they're giving this medication to a child, they have to take it with something fatty, something greasy. So you think they can take it with cereal in the morning? No, there's not much fat, right? They can take it with eggs or something that has fat in it, because it's that fat that actually activates, that makes this medication active. So you're going to teach them to eat it with high-fat foods for best absorption. Periodic testing is required to monitor leukopenia and assess liver and renal function. Let's move on to viral infections. Verruca warts. Warts are of a viral nature, and in the comments, look, they tend to disappear spontaneously. As you know, with viruses, guys, we treat them symptomatically. They're going to come and they're going to go. Autoinoculable. Herpes virus. You know, you have your type 1 and type 2. Type 1 tends to be above the belt, around the mouth area. Type 2 tends to be below the belt. Excuse me, in the genital area. Herpes simplex, a virus. Groups, burning, itching, vesicles, or inflammatory base. And I underline that word vesicles because 90% of the time, when you guys are testing, if you see vesicles and you have no idea what they're talking about, 90% of the time, if it says vesicles, they're talking about something that's of a viral nature. Not all the time, but most of the time. So if you're not sure, go with viral, okay? So anyways, group burning and itching vesicles on inflammatory base, management, avoidance of secondary infection, because what happens, remember it's burning and it's itching. So what happens, they might be scratching or irritating that area. Now the skin integrity decreased and now pathogens have gotten into that area. Now the patient may have a bacterial infection. Okay, that's a secondary infection. They're going to get oral antiviral agents such as acyclovir. Remember acyclovir, guys? Last semester, yes. Acyclovir for the initial infection. Then valacyclovir, which is an oral antiviral for episodic treatment of recurrent genital herpes. So make sure you guys know that. In the comments, look, it may be fatal in children with depressed immunity. So we're talking about those children who are on chemotherapy, or they're getting radiation, or they have HIV or AIDS, or they're organ transplant recipients and they're on high dose steroids. Whatever it is, if they're immunosuppressed, this can kill them. Okay? Varicella zoster virus. When you see varicella zoster virus, you're thinking of chickenpox. All right? Management. Analgesics is painful for the child. Acyclovir or valacyclovir. And look at this, very important to note, and I told you a million times, NCLEX is very big on primary prevention measures, okay? Preventative vaccine is available for persons older than 50 years old. Comments. Post-herpetic pain does not occur in children. In parentheses, I wrote shingles for adults. Chickenpox may follow exposure. You're going to isolate the affected child from other children in a hospital or school, and may occur in children with depressed immunity, and it can be fatal. Something else I wanted to bring to your attention. Whenever you're studying and the author, the book tells you that may occur with depressed immunity, what they're also telling you is whatever it is that they're talking about, do you think that type of patient can get that live vaccine? No. Okay. Next, molluscum contagiosum. Flesh-colored papules, about 1 to 20. Management, cases in well children resolve spontaneously at about 18 months. This is distressing to the parents because they're like little bumps on the child, and they're going to be distressed, but you let them know it's a viral nature. It's going to clear on its own. Look at the comments. It's spread by skin-to-skin contact, including auto-inoculation. Next, let's talk about dermophytoses, the fungal infections. And you guys absolutely do have to know the difference in the fungal infections. Don't shoot the messenger. All right, tinea capitis. You see that CAP cap? Think about the cap you put on your head, okay? So that's the fungal infection that the patient has on their head, on their scalp. Management, oral griseofulvin. Remember, they have to eat something fatty with that. Oral ketoconazole for difficult cases. Selenium sulfide shampoo used twice a week. And over here in the comment section, person-to-person transmission, animal-to-person transmission. Now, tinea corporis. In Creole, cor means the body. And this is what it is. It's fungal infection on the body. Again, management, oral grisio. Comments, usually of animal origin. So you're going to also have them check their pets. Tinea cruris, that's what's known as jock itch. Skin response similar to tinea corporis. Cruel fold may involve scrotum in males. So we tend to see this in the folds by the genital area. It's very itchy. Next, tinea pedis, the foot, often seen between the toes or on the plantar surface of the foot. Look at this in the comments for tinea pedis. Common in locations such as showers, like going to the gym and using your shower at the gym. Locker rooms, swimming pools, where fungi proliferate. Candiasis. Oh. Management, neonates, thrush, oral, nystatin. Nystatin is your key. If they have it orally, they have the thrush, they'll get the solution wash. Or if they have it down here, diaper dermatitis, right? They'll get the nystatin cream. But nystatin is your key for this. Comments common from diaper dermatitis. That's your diaper rash. Let's jump to page 1535. Skin lesions caused by arthropods. Everyone there? Ticks, and in parentheses, I think of Lyme disease. So ticks, mechanism. Excuse me, guys. In process of sucking blood, head and mouth parts are buried in the skin. Manifestation. The ticks, usually attached to the skin, may cause urticaria. Remember urticaria, that's when they break out in hives. May cause urticaria or persistent localized edema. Treatment. This has shown up on NCLEX quite a few times. Make sure that you know this. Grasp the grass tick with, does it say fingers? No, it said tweezers. Tweezers or forceps as close as possible to the point of attachment. Don't ever use your fingers. Pull straight up with steady, even pressure. If using bare hands, I promise you guys, I know this book is saying it's using bare hands, but for testing purposes, you never use your bare hands, okay? There's always a tweezer available and you choose that answer choice. If using bare hands, use a tissue to touch tick during removal. You're gonna wash hands thoroughly with soap and water. For prevention, teach children to avoid areas where prevalent. Let me stop right there because it's shown up a couple times where they'll ask about, areas. So those grassy areas, or I forgot what you call them, but the thing on by the roof where like if it rains where the leaves fall. Gutter. Yes, gutter. Okay, so you're going to teach the parents to have the children wear long slacks and to put their socks over their slacks so nothing can get in, and to wear long sleeves and just to cover their skin. Prevention, teach children to avoid areas where prevalent, inspect skin, especially scalp, after being in wooded areas. High grass wooded areas or gutter, near gutters. Scabies. Scabies is an endemic infestation caused by the scabies mite. The lesions are created as the impregnated female burrows. This is the key when you see that word burrows. The female burrows into the stratum corneum of the epidermis, never into living tissue. So it's right down the top, and deposits her eggs and feces. And this causes intense itching. The inflammatory response causes intense pruritus that leads to punctate discrete excoriations secondary to the itching. So the child can cause himself to have a secondary bacterial infection because they've been scratching so much. Maculopapular lesions are characteristically distributed in intertriginous areas. And that word intertriginous areas, all it means is skin folds. So where we tend to find the scabies, guys, is right here in the armpits where these folds are, right? Between the fingers, between the toes, right here in the folds of the genital areas, okay? Interdigital surfaces, axillary cubital area, popliteal folds, inguinal region. The observer must look for discrete papules, burrows, that's your key when you see that. I want you to be thinking of scabies, or vesicles. Scabies is transmitted primarily through prolonged close personal contact and it affects persons regardless of the age, sex, personal hygiene, and socioeconomic status. Nursing care. The drug of choice, ding, ding, ding. The drug of choice for children, infants older than 2 months is the permethrin 5% cream. That's your elamite. Alternative drugs are 10% crotamycin or oral ivermectin. Here's the thing. Ivermectin, an oral medication, it can be used to treat scabies. Sorry. It can be used to treat scabies in patients with secondary excoriation for who the topical scabicides are irritating and not well tolerated. So remember the drug of choice, which is our permanent. What happens if they're scratching so much, it causes themselves to get a secondary infection. That area is very irritated. So if they get the permanent, it might cause a burning sensation for them. And so what the author is letting us know, even though this is a drug of choice, if it's causing that burning, sensation because that area is just really raw, then we can give this as a second choice. But number one is going to be the permanent, okay? All persons who are in close contact with the affected child needs treatment, which means who? All family members, everybody living in the house with that child. The picture with child with scabies. Enough medication for the entire family should be prescribed, with 2 ounces allowed for each adult and 1 ounce for each child. Pediculosis capitis. That's head lice, guys. Let's go to therapeutic management. You guys know what head lice is. The drug of choice for infants and children is Permethrin 1% cream rinse. That's the NICS, which kills adult lice and nits. Most experts advise a second treatment about 7 to 10 days to ensure a cure. Nursing care management. Nurses should emphasize that anyone can get pediculosis. It has no respect for age, gender, socioeconomic status, cleanliness. Lice do not jump or fly, but they can be transmitted from one person to another on personal items, such as hats, scarves. Children are cautioned against sharing combs, hair, ornaments, hats, caps, scarves, coats, and other items used on or near the hair. Lice are not carried or transmitted by pets. Nurses or parents should carefully inspect children who scratch their heads more than usual for bite marks, redness, and nicks. Nurses should wear gloves when examining the hair. Lice are small and grayish tan. They have no wings. Remember, they don't fly, and they're visible to the naked eye. The nits or eggs appear as tiny whitish oval specks adhering to the hair shaft about 6 millimeters from the scalp. The adherent, that word here, means to stick to. The adherent nature of the nits distinguishes them from dandruff, which falls off readily. If evidence of infestation found, the child must be treated according to directions on the label of the pediculicide. An extra fine-tooth comb that is included with many commercial pediculicides or is available at community pharmacy facilitates manual removal. And the reason it has to be very fine, remember guys, they like to stick, they like to adhere. So that the comb has to be very fine-tooth so you can get to them. Live lice survive for up to 48 hours away from the host, but nits are shed into the environment and they're capable of hatching in 7 to 10 days. Retreatment is required. Focus preventing the spread and recurrence of pediculosis. You're going to machine wash all washable clothing, towels, bed linens, all that good stuff. And if it can't be machine washed, what you're going to do, guys, is put it in a plastic bag and seal it so that you can suffocate them. Okay? So you're going to machine wash everything that's washable, and you're going to put it in the dryer for at least 20 minutes. You're going to thoroughly vacuum the carpets, car seats, pillows, stuffed animals, rugs. Seal non-washable items in a plastic bag for 14 days if they're not able to be dry cleaned or vacuumed. You want to suffocate. You want to suffocate them. You're going to soak the combs, brushes, and hair accessories in a life-killing product for 1 hour or in boiling water for 10 minutes. In daycare centers, you're going to store children's clothing items such as hats and scarves and other headgear in separate cubicles. Discourage the sharing of items such as hats, scarves, hair accessories, combs, etc. Avoid physical contact with infected individuals and their belongings, especially clothing and bedding. Provide educational programs on the transmission of pediculosis, its detection and treatment. Rocky Mountain spotted fever. What did I want you guys to know about that? I have a highlighter. Someone, please. Thank you.
How many were?
Thank you. Let me read. I'll tell you what you need to know.
Well, here.
Really?
It matches the one you were using. It's gonna bug me.
Yeah, nothing here. Moving on. Not nothing here. You know what I meant, guys. Everything's important. Okay, miscellaneous skin disorders. Urticaria, usually allergic response to drugs or infection. Psoriasis, the cause is unknown. Hereditary predisposition may be triggered by stress. There's something about psoriasis, give me a second. Let's see. Here, silvery scales. When you see silvery scales, think of psoriasis. And I'm not going to read all of this, it's somewhere in here. It's not contagious. Alopecia, hair loss. Stevens-Johnson syndrome, you guys know about this from last semester. It's fatal, it's deadly, the skin condition. Diaper dermatitis. Patho and clinical manifestation. Diaper dermatitis is caused by prolonged and repetitive contact with irritants such as urine, feces, soap, detergent, ointments, friction. Although the irritant in most cases is urine and feces, a combination of factors contributes to irritation. So what to tell you, it's very important that the patient is changed often. They can't sit with that feces or urine on the skin because if it keeps happening, they can develop diaper dermatitis. Prolonged, and guys, you know fungus love moist, dark environment. Prolonged contact of the skin with diaper wetness produces higher friction, greater abrasion damage, increased transepidermal permeability, and increased microbial counts. Poor thing. Other causes are detergents or soaps from inadequately rinsed cloth diapers or chemicals in disposable wipes. Perianal involvement, usually the result of chemical irritation from feces, especially diarrheal stools. If the patient has diarrhea, you're going to have to change your diaper much more often. Nursing management. The most significant factor amenable to intervention is the moist environment created in the diaper area. Changing the diaper as soon as it becomes wet eliminates a large part of the problem, and removing the diaper to expose healthy skin to air facilitates drying. So let's say they just had a bowel movement, you clean them up, instead of putting another diaper on them while, you know, that area might still be wet from the wipe, let it be open to air, let their skin breathe. The use of a hair dryer or heat lamp is not recommended because these devices can cause burns. And of course, someone had to try it. That's why I was in the book, right? Atopic dermatitis, also known as eczema. Atopic dermatitis is a chronic, relapsing inflammatory skin disorder that results in itching and lesions. Before I go on to the next page, take a look at this box about controlling diaper rash. Again, you want to keep the skin dry. You're going to use super absorbent disposable diapers. You're going to change the diapers as soon as they're soiled. Expose healthy or only slightly irritated skin to air. Let that skin breathe. Apply ointments such as zinc oxide or petroleum to protect the skin, especially if the skin's red or has moist open areas. You're going to avoid removing skin barrier cream. That barrier cream is there for a reason to protect the skin. Avoid overwashing the skin. Gently wipe stool from the skin and use disposable wipes, preferably non-scented. Okay, back to eczema. Therapeutic management for eczema. The primary goals of management are, one, to hydrate the skin, because the more dry that the skin is, the more it's gonna itch. So we want to keep that skin hydrated. Two, relieve the pruritus. Three, reduce flare-ups or inflammation. And four, prevent and control secondary infections from scratching so much. Avoiding exposure to skin irritants or allergens, avoid overheating, and administering medications such as antihistamines, topical immunomodulators, topical steroids, and sometimes mild sedatives as indicated. A tepid bath with mild soap such as Dove or Neutrogena, no soap, or an emulsifying oil followed immediately by application of an emollient within 3 minutes helps to trap the moisture and prevent its loss. Bubble baths and harsh soap should be avoided. Aquaphor, Cetaphil, Eucerin are acceptable lotions for skin hydration. And one thing you're going to teach the parents is after you give the child a bath, instead of drying that child completely, remember they have eczema, and the big part of that problem is the dryness. So instead of drying the skin completely, while the skin is still damp, that's when you put on the Eucerin or the Aquaphor, because that dampness seals in that moisture and it keeps the moisture in the skin for a lot longer. Oral antihistamine drugs such as hydroxyzine or diphenhydramine usually relieve moderate or severe pruritus. They can also get non-sedating antihistamines such as Claritin, Allegra. And Claritin, Allegra can be preferred for daytime pruritus relief. Because pruritus increases at night, a mildly sedating antihistamine may be needed. They can get topical steroids. We have to be careful with these topical steroids, guys, because as you know, you guys learned this last semester, one of the concerns with this is that it can cause discoloration of the skin if it's used for too long, so we have to be careful with it. Topical immunomodulators. A non-steroidal treatment for AD are best used at the beginning of a flare-up, just as the skin becomes red and itches. Second-line management for children with AD includes immunomodulator medications such as tacrolimus. I'm not going to try to pronounce those two drugs. You see it, make sure you know. Nursing care management. You're going to keep the fingernails and toenails short, because what are they going to do? They're going to scratch themselves. So you want to keep them short, clean, and filed frequently to prevent sharp edges. Gloves or cotton stockings can be placed over the hands and pinned to shirt sleeves. One-piece outfits with long sleeves and long pants also decrease direct contact with the skin. If gloves or socks are used, the child needs time to be free from such restrictions. An excellent time to remove the glove, socks, or other protective devices is during the bath or after receiving a sedative or antipruritic medication. Woolen clothes or blankets, rough fabrics, furry stuffed animals are removed from the child's environment because heat and humidity causes perspiration, which makes the itching even worse. Proper dress for climatic conditions are essential. Pruritus is often precipitated by exposure to irritant effects of certain components of common products, such as soaps, detergents, fabric softeners, perfumes, and powders. So during the cold months, you're gonna have them have synthetic fabrics, not wool. Exposure to latex products, such as gloves and balloons, should be avoided. Children with eczema tend to have asthma, and they tend to be allergic to lots of things. So we have to be careful. Clothes and sheets are laundered in mild detergent. When they're getting a bath, the water's kept tepid, and the soaps. Let me read that. The water's kept tepid, and soaps, except as indicated. Bubble baths you're going to stay away from. Oils and powders are avoided. Skin folds and diaper areas need frequent rinsing with plain water. And after it's been rinsed, remember, you're going to not wipe, but you're going to pat You're gonna pat it dry, but allow it to still be a little damp so that when you put on, the cream, it can be sealed in. Skin lesions are examined for signs of infection. Any sign of infection is reported to the healthcare provider. If the child's being treated with bath, an emollient preparation must be applied immediately after bathing. Look at this. While the skin is still slightly moist, we want to seal in that moisture. And we do this to prevent drying. Excessive use of an agent, especially steroids, can be hazardous. So we don't do that regularly. That's done routinely. All right, let's jump to page. What's that? Tomorrow?
Tomorrow and Thursday. Well, they're already off Friday, so they're off the rest of the week.
What about Broward? Come on, Broward. Let me know if you hear anything about Broward. Okay. Make sure that you guys excited? Oh, because this school follows the.
Yeah.
Okay. All right. I'm excited too now. My students are excited. They have an exam tomorrow, so I know they're happy. All right, let's keep going. Excuse me. So this is a tropical depression or really like a hurricane?
I think it's a one.
Oh my gosh.
It's hitting tomorrow night.
Tomorrow night? Okay.
No, it's fine.
Okay, guys, let's focus. We'll talk about this hurricane in a second. Get to this information.
It's always been her class.
What's that?
The last time we.
Oh, fine. All right, make sure that you guys know the percentage rates for the affected areas for burns. To be honest, I know I both of these I said to know. However, but I don't write NCLEX guys. However, traditionally speaking, if they tend to give a question on burns, it'll be the adult one or this one. It's never gotten back to me that NCLEX has given this one, but you never know. So just make sure you guys know both of these, okay? All right, moving on. Depth of injury. Superficial or first degree burns. These are usually of minor significance. First degree burns or superficial burns. They're not that bad. They're bad, but they're not that bad. Tissue damage is minimal and there's no blistering, right? Next, partial thickness burns, also known as second degree burns. These involve the epidermis and varying degrees of the dermal layer. These wounds are painful, moist, red, and guess what? They do blister. Next, third degree burns, also known as full thickness burns. These are serious injuries that involve the entire epidermis and dermis, and they extend into the subcutaneous tissue. Nerve endings, sweat glands, hair follicles are destroyed. The burn varies in color from red to tan, waxy white, brown, or black. It's distinguished by a dry, this is your key guys, leathery. Dry, leathery appearance and texture since elasticity of the dermis is compromised. And guess what? Normally, full thickness burns lack sensation to the area of injury because remember, those nerve endings have been damaged. Make sure you guys take a look at figure 50.14, the classification of burn depth according to depth injury, the appearance of the wound, wound sensation. All right, let's move on. Fourth degree burns. Fourth degree burns are full thickness burns that involve underlying structures such as muscle, fascia, and bone. The wound appears dull and dry, and ligaments, tendons, and bone may be exposed. So who do you think is at the highest risk for infection, first or fourth? Okay. By the way, when it comes to burns, you are always going to be concerned about dehydration, decreased fluid in the vessel because all the fluid goes out the tissue. That's why that patient's swollen, but they're dehydrated, right? And we're worried about fluid electrolyte balance. You're going to be concerned about infection because remember, your skin's the first line of defense. And what's my third one? Give me a second, guys. Let me think. Pain. Remember how I always tell you, pain never killed anyone except in certain situations, and burns one of them. Burns, sickle cell, MI, and stone. Those 4 situations, you are going to treat pain just like you do vital signs and anything else that affects physiological integrity. Also, I didn't warn you. All right, treatment of burns.
Is there a particular electrolyte that we have to monitor for burns?
Absolutely. You're going to be looking at that sodium. You're going to be looking at the sodium, and you're going to be looking at the, what's that type of protein in blood? Albumin.
Nutrition status.
I'm sorry?
Nutrition status.
Oh, yes, definitely nutritional status. Okay, guys, treatment. Make sure you guys look at this box on the side, because I refuse to read all that. But on the side, I wrote treatment. I wrote dehydration, infection, swelling. And because you guys tend to need to write pain, get confused because when the patient has a burn, remember how you take off? Thank you. Remember how you take off like the watch and the tie and the restrictive clothing because they swell up. But because they look so swollen, you can't wrap your mind around them being dehydrated, but they really are, because when we're talking about dehydration, we're talking about fluid within the vascular space. Once that patient has a really bad burn, that albumin leaves the vessel. And guess what? Albumin is what's keeping all the fluid within the vessel. So as soon as albumin's gone, so is all the fluid. So even though that patient's all swollen, they're dehydrated, and you have to rehydrate them because that can cause them to what? Go into shock. Okay? Okay, thank you. All right. Major burn management. You're going to ascertain the adequacy of airway. Remember how all of the fluid leaves the vascular space and goes to the tissue and everything gets swollen? We're going to be concerned about the airway being occluded. And then don't forget, if there was a burn and the patient inhaled all of the noxious gases, that could cause spasms of the airway. So that's going to be our primary concern, airway. Insert a large bore IV line. We are giving that patient fluids hard and fast. We do not want them going into shock. Remove clothing and jewelry. Why? Because they're going to swell up very quickly. Obtain admission weight. In parentheses, I put fluid status. The number one way that we're going to be able to monitor the patient's fluid status is not INO, it's not skin turgor. It is and always will be daily weights. You're going to take their weight in the morning, same scale, same type of clothes. You're going to calculate the fluid requirements. You're going to provide IV medication for control of pain and anxiety. NG tube. Remember, guys, you want to decompress that stomach, and we're going to be concerned about them getting ulcers. Insert indwelling Foley catheter. We're going to have to do strict INOs. Perform escartomy or fasciotomy if they have compartment syndrome. And we're going to be concerned about compartment syndrome because of all of that swelling and possible nerve damage or compression of the nerves. Apply topical antimicrobials. Remember, infection is a big concern. Administer the appropriate tetanus prophylaxis, and prophylactic antibiotic administration is not recommended. We're going to treat as needed. Acute management of burns. Make sure they have a stable body temperature. Adequate fluid replacement and urinary output. What is the first organ that lets us know that patient's going to shock? Thank you, the kidneys. You guys are killing me. You guys still think about this hurricane, aren't you? Yeah, I let you guys go early last time. That's what you're hoping for? Gotta get through this, guys. Come on. Hang with me. Adequate nutrition and reduction of metabolic losses. Let's talk about this adequate nutrition. We're gonna make sure that patient gets lots of protein. Remember, albumin is a type of protein. The reason all the fluid left the vascular space is because albumin was like, I'm out, right? So we're gonna give that patient protein. We're gonna increase that protein, get that protein in the vessels, get more fluid in the vessels. We're gonna keep that patient perfused. This is what we want. The patient's gonna get protein. And another reason protein is good. Protein is good for what? Wound healing. So they're gonna get protein for those two reasons, and we're gonna give them vitamin C.
Question, if the patient has kidney issue, do we still give a lot of protein?
Oh my gosh, that is for the nephrologist. Leave that up to the nephrologist. I couldn't even tell you. I would leave that to the nephrologist. We're gonna make sure we control pain. Remember, pain is a priority. Evidence of wound healing. We want no evidence of contractures. We're gonna try to do not ADLs, range of motion with that patient as much as possible because we don't want them to develop contractures, and adequate emotional support. Type of skin grafts. I'm not gonna go over all of these. However, if you get a question on skin grafts, the one they ask most often about is the autograft. So make sure you know that this is tissue obtained from undamaged areas of what? The patient's own body. That's why it's auto, from the body. Okay. Sunburn. You guys are killing me. Give me 5 more minutes, and I'll give you a 10-minute break. Hang with me, please. Sunburn. Sunburn is a common skin injury caused by overexposure to UV light waves, either sunlight or artificial light in the UV range. Nursing care management for sunburns. Local application of cool tap water soaks or immersion in a tepid water bath. Temperature slightly below 98 degrees for 20 minutes or until the skin is cool. This limits the destruction and relieves the discomfort. After the cool applications, aloe gel or bland oil and water moisturizing lotion can be applied. Protection from sunburn is the primary goal management. The skin should be covered with clothing, and sun protection agents approved by the U.S. Food and Drug Administration should be applied. There are 2 types that are available for skin protection. One is a topical sunscreen, and that partially absorbs the UV light. And 2 are sun blockers, which block out UV rays by reflecting sunlight. Most sunscreens have SPF ranging from 2 to more than 30. The higher the number, the greater the protection. Sunscreens are applied evenly to all exposed areas. Something that's important to know, guys, the sunscreen is not waterproof. I don't care what those advertisements claim. As soon as they come out of the water, it needs to be reapplied. You're going to avoid eye contact.